ओके सो गाइस, हाई इम्पॉर्टेंट टॉपिक सीरीज का पार्ट 3 और इम्पॉर्टेंट का भी सबसे ज़्यादा इम्पॉर्टेंट medical disorders in pregnancy is what we are going to start right now. First, we will be covering most of the medical disorders of pregnancy in slight, summarized way. Then, hypertension, anemia, heart diseases, इन सब टॉपिक्स को हम लोग थोड़ा डिटेल में भी डिस्कस करेंगे. So pregnancy can unmask, worsen or be complicated by pre-existing or new onset medical conditions. पहले से हैं वो वर्सन हो सकती हैं, पहले नहीं है नई मेडिकल कंडीशंस पैदा हो सकती हैं, ऑलरेडी एग्जिस्टिंग मेडिकल कंडीशंस की वजह से प्रेगनेंसी कॉम्प्लिकेट भी हो सकती है. Proper management is essential for maternal and fetal safety. First, let us discuss in slight summarized form about hypertensive disorders. There is something called as chronic hypertension, which is present before pregnancy or in less than 20 weeks of period. Blood pressure more than 40/90 at least at two separate occasions, measured 12 hours apart, may be associated with superimposed preeclampsia. अगर ये आगे जाके preeclampsia से superimpose हो सकती है. Gestational hypertension is the new onset hypertension after 20 weeks without proteinuria. In preeclampsia, there is BP more than 140/90. There is proteinuria more than 300 mg per 24 hours or features of severity like thrombocytopenia, increased liver function, enzymes, and renal dysfunction and CNS symptoms. There can be eclampsia, which is preeclampsia with seizures. The management involves labetalol, nifedipine, methyl-dopa, MgSO4 for seizures, and delivery if it is a term patient or the features are severe. This was a slight summarized form. We'll discuss these hypertension, diabetes, anemia, all these, and heart diseases, all these in detail. Now comes diabetes in pregnancy. Gestational diabetes mellitus, glucose tolerance diagnosed during pregnancy. Screening is done by 75 gram glucose test. For if after 2 hours the blood sugar is more than 140 mg per deciliter, called the DIPSI method, the patient is said to be diabetic. Pre-existing diabetes 1 or type 2, the management involves diet, exercise, and insulin if required. We have to monitor glucose, fetal growth, because there is a high risk of macrosomia. Okay. Now, we have to monitor the patient for congenital anomalies, especially heart. Now, the thyroid disorders, we have to assess the patient for hypothyroidism because it is common. TSH more than 2.5 milli-international units per liter in first trimester is abnormal, and we have to treat it with levothyroxine. Hyperthyroidism can also be there due to Graves' disease. We have to treat it with propylthiouracil (PTU) in first trimester and carbimazole after that. We have to avoid radioactive iodine. There can be some cardiac diseases in which rheumatic heart disease, mitral stenosis is most common in India, and increased cardiac output in pregnancy can lead to increased risk of decompensation. The management involves risk assessment via NYHA classification, antibiotic prophylaxis for endocarditis if indicated, and we have to avoid volume overload during labor. Now, hematologic disorders in anemia, like most common anemia is iron deficiency anemia, diagnosed if hemoglobin is less than 11 grams per deciliter according to WHO. We have to treat it with oral or IV iron, and folate can be given as needed. Sickle cell disease and thalassemia may worsen in pregnancy. Folic acid transfusions, and we have to avoid crisis. Genetic counseling is important. Some infectious diseases can be there like HIV. We have to supply antiretroviral therapy throughout pregnancy. In foreign countries, sometimes breastfeeding is avoided, but in India, we use exclusive breastfeed plus antiretroviral therapy. In hepatitis B, neonatal immunoprophylaxis is given, HBV vaccine and HBIG is given, and immunoglobulin is given. And UTI, we have to treat with safe antibiotics like nitrofurantoin and cephalexin. Now, in case of epilepsy, we have to treat the risk of teratogenicity from all these teratogenic drugs. Okay, monotherapy at lowest effective dose is prescribed. Okay, anti-epileptic drugs all cannot be given. Okay, some are reserved. Folic acid can be given 4 mg per day preconceptionally, and we have to monitor the drugs level as well. About renal disorders, it is that UTI and pyelonephritis are common. Chronic diseases are there in which risk of IUGR, preterm labor, worsening renal function can be there. You have to monitor BP, renal function, and fetal growth. Around respiratory disorders, asthma usually improves or stays the same, and safe drugs are inhaled beta antagonist and beta agonist and corticosteroids, and we have to monitor fetal growth also. Some autoimmune conditions can be there like SLE, systemic lupus erythematosus. There is risk of flares, preeclampsia, IUGR, continued safe medications like hydroxychloroquine, and we have to avoid conception during the flare period. APLA or the antiphospholipid syndrome can be there, due to which there will be recurrent pregnancy loss, and this has to be treated with aspirin and heparin. Now, something about mental health disorders, they can be depression, anxiety, bipolar disorders. Antidepressants are used with cautions. In new mothers, we focus more on this mental health disorders, and in the patients who are aspiring for a boy and the mother is under very much stress that whatever it's a girl, then we have to emphasize on psychological support. We have to give some safe medications, and postpartum monitoring should also be done. Okay, so a summary table is there, like hypertension, the risk is preeclampsia and IUGR, and management is by labetalol, nifedipine, magnesium sulfate. In gestational diabetes mellitus, the risk is of macrosomia or stillbirth, and management is through diet or insulin. In hypothyroidism, the risk is cretinism or miscarriage, and treatment is by levothyroxine. In cardiac diseases, the risk is of heart failure or embolism. Management is by NYHA grading or multidisciplinary care. Now about anemia, the risk is preterm labor, low birth weight. Management is by iron therapy. In HIV, there is a risk of transmission of HIV to the baby, and the management is by ART, antiretroviral therapy, and safe delivery practices. And in epilepsy, there can be teratogenicity because of anti-epileptic drugs, or they have to be adjusted, and high folic acid has to be supplied. Okay, so this was a very important topic. Now let us come on to all the details of individual diseases, first being the anemia in pregnancy. Definition by WHO criteria: hemoglobin less than 11 gram per deciliter in pregnancy is termed as anemia. Severity is mild, moderate, severe, or very severe. Mild is less than 11 to 10.9. Moderate is 7 to 9.9. Okay, 10 to 10.9, 7 to 9.9. Severe is less than 7, and very severe is less than 4 grams per deciliter. The types and causes can be nutritional, like iron deficiency anemia, most common, folic acid deficiency, vitamin B12 deficiency. There can be non-nutritional causes like hemoglobinopathies, thalassemia, sickle cell disease, chronic infections like malaria, TB, bone marrow suppression can be there, but it is rare. Pathophysiology of iron deficiency anemia: increased demand during pregnancy is there, like 1000 milligram of iron is required. Physiological hemodilution is there because plasma volume is increased and more RBC mass is there. Inadequate dietary intake of iron, poor absorption of iron, or blood loss in menstrual cycle, or any parasitic infection can all lead to iron deficiency anemia. Now, investigation: hemoglobin estimation has to be done by CBC. Peripheral smear is made in micros, and what we see in that is that RBCs are microcytic, smaller in size, and hypochromic, less than 1/3 tailor is there in the RBCs in iron deficiency anemia. Serum ferritin is low in iron deficiency, less than 15 nanogram per ml. Only one thing is increased, that is the TIBC, total iron binding capacity of ferritin. Okay, serum iron we have to measure, TIBC we have to measure, transferrin saturation has to be measured, reticulocyte count has to be done, and stool examination for helminths like hookworm has to be done. Management, iron and folic acid supplementation is done as management. In prophylactic dose, 60 milligram elemental iron plus 500 microgram folic acid from second trimester onwards is supplied. Therapeutic dose, 120 milligram iron with 1 milligram folic acid daily is given. About the parenteral iron therapy, indications are poor compliance, malabsorption, late pregnancy after 34 weeks, hemoglobin less than 7 gram per deciliter with symptoms, iron sucrose or ferric carboxymaltose. These are preferred because oral iron is not well tolerated. Okay, so iron sucrose or ferric carboxymaltose is the preferred agent. Next up is blood transfusion if the anemia is severe, hemoglobin 5 to 7 gram per deciliter with symptoms, imminent delivery and very low hemoglobin. In all these cases we do blood transfusion and always done in hospital setting. There is focus on diet and deworming. Iron rich foods like green leafy vegetables, jaggery, lentils are given. The foods which enhance the absorption of iron like acidic foods rich in vitamin C are given, and deworming is done. Albendazole tablet is given 400 milligram after single dose after first trimester. Now, what can be the complications due to anemia? Maternal complications are more because the fetus serves as a parasite, so there are not much fetal complications as compared to maternal. The mother can be in fatigue, infection, preterm labor, postpartum hemorrhage, and cardiac failure can also occur in very severe anemia. About the fetal causes, there can be intrauterine growth restriction, low birth weight, perinatal mortality, or poor neonatal iron stores, but none of these is very much significant. Maternal complications are more significant in case of anemia. The preventions guidelines in India, IFA tablets are started from second semester onwards. Weekly iron for adolescent girls is prescribed. Food fortification, dietary diversification, deworming and malaria control in endemic areas is done. Okay, so this was anemia. Anemia is important topic. Anemia in pregnancy comes as a long question, as a short note in your examinations, and it is something that you will encounter very frequently in any hospital setting, be it government or private. Anemic mothers are very common to find in India. Next up, coming to hypertensive disorders in pregnancy, a very important topic. Hypertensive disorders are among the top 3 causes of maternal mortality, defined as blood pressure more than 140 by 90 millimeters of mercury, measured on 2 occasions 4 to 6 hours apart after 20 weeks of gestation. The classification by AACOG and ISSHP is there can be chronic hypertension which is present before pregnancy or less than 20 weeks or persist more than 12 weeks after postpartum. All of that is chronic hypertension. Gestational hypertension can be there, that is new onset hypertension after 20 weeks with no proteinuria or organ dysfunction is called as gestational hypertension, and this usually resolves after delivery. There can be preeclampsia. Preeclampsia is hypertension with proteinuria and or end organ dysfunction after 20 weeks. Eclampsia can be there, which is preeclampsia plus seizures, and chronic hypertension with superimposed preeclampsia. In patients with chronic hypertension, new proteinuria or organ damage can occur. So this classification of the types of pregnancy-induced hypertension is important. Now, a detailed overview on preeclampsia and eclampsia. Preeclampsia diagnostic criteria is that proteinuria, of course, hypertension is there, BP is more than 140 by 90, and other than that, proteinuria more than 300 milligrams in 24 hours or more greater than equal to +1 on dipstick. The features of severity can be thrombocytopenia, platelets less than 1 lakh, elevated liver enzymes, serum creatinine more than 1.1 mg per deciliter, pulmonary edema, CNS symptoms like headache, blood vision, etc. Also, there can be severe preeclampsia, BP more than 160 by 110 millimeters of mercury with any severe feature above. Okay, now eclampsia. What is eclampsia preeclampsia plus seizures. New onset tonic-clonic seizures in a woman with preeclampsia is eclampsia, and this is a life-threatening emergency. What are the risk factors for eclampsia? Primigravida, multiple pregnancy, history of preeclampsia, obesity, chronic kidney disease, autoimmune diseases like SLE, diabetes, chronic hypertension, investigations, CBC, chronic hypertension, all these can be the risk factors. Investigations to be done are CBC, platelet count, LFT, KFT, urine protein, dipstick or 24 hours, either will suffice. And USG can be done for fetal biometry, AFI, Doppler. Fundus examination can be done for retinal changes because the blood pressure is high. It can also affect the retina of the eye. Wow. Now, management. Gestation hypertension. The management is by monitoring the blood pressure and fetal growth, and antihypertensives are prescribed if the blood pressure is more than 150 by 100 mm of Hg. What about preeclampsia? If the preeclampsia is mild, monitor blood pressure and proteinuria and fetal growth as well. Plan delivery at 37 weeks. If it is severe, then admit the patient, control blood pressure, and monitor mother and fetus conditions. About eclampsia, you have to stabilize first. Magnesium sulfate, MgSO4, is the drug of choice. Loading dose is 4 gram IV or 10 gram IM or 5 gram on each buttock. Okay, 4 gram IV is given and 10 gram IM, 5 gram on each buttock is given, and maintenance is given by 5 gram IM every 4 hours on alternate buttocks. Okay, then we have to control blood pressure by labetalol and nifedipine, and we have to plan for delivery once stable. Antihypertensive drugs in pregnancy. Labetalol is a beta blocker and first line drugs. Nifedipine is a calcium channel blocker and is also the first line drug for management of blood pressure. Methyl dopa is alpha 2 agonist, and this is also safe in long term. What are not to be used? What are teratogenic drugs? They are ACE inhibitors or ARBs. They are contraindicated in pregnancy. Now, what are the complications? Maternal complications are HELLP syndrome, hemolysis, elevated liver enzymes, low platelets. Of course, preeclampsia can manifest into eclampsia. There can be abruptio placentae. The placenta can rupture. Pulmonary edema can be there. Renal failure can be there. DIC can be there. And fetal complications include IUGR, oligohydramnios, prematurity, IUFD, intrauterine fetal death. The prevention involves low dose aspirin 75 to 150 mg per day from 12 to 16 weeks till 36 weeks in high risk women. Calcium supplementation in low calcium intake population can also be done. Okay, so this was the second very important topic of hypertension. Next, we'll discuss the heart diseases in pregnancy. Why it's important to discuss it? Because pregnancy increase cardiac load. 2. Increase the blood volume by 30 to 50%. There is hemodilution, if we know. There is increased cardiac output by 40%, and there is decrease in systemic vascular resistance, that is, the patient is in vasodilated state. These changes can unmask or worsen the cardiac conditions and increase maternal morbidity and mortality. Now, the classification for cardiac disease in pregnancy, the most common being the rheumatic heart disease, or called the manifest as most commonly as mitral stenosis, the bicuspid valve stenosis, or mitral regurgitation, and can lead to pulmonary edema, atrial fibrillation. Next up are the congenital heart diseases like ASD, atrial septal defect, VSD, ventricular septal defect, PDA, patent ductus arteriosus, or TOF, teratology of Fallot, repaired or unrepaired. The risk depends on the type and repair status. There can be cardiomyopathies. Peripartum cardiomyopathy develops in last month of pregnancy or with 5 months postpartum and presents with heart failure. There can be ischemic heart disease, but it's rare and may occur due to hypercoagulability or atherosclerosis. So, as we know, there is NYHA classification. Class 1 is when the patient has no symptoms and no limitation of activity. In class 2, there is slight limitation during ordinary activity. In class 3, there is marked limitation, but the patient becomes comfortable at rest. And class 4 is symptoms are present at rest and unable to carry out any activity. The class 1 and 2 are usually tolerant to pregnancy, but class 3 and 4 are high risk classes and may need to avoid or even terminate the pregnancy. What are the clinical features? The patient will complain of dyspnea, painful respiration, especially on exertion or lying down, orthopnea, paroxysmal nocturnal dyspnea. When the patient lies down in night, he feels discomfort. The patient will complain of fatigue, palpitations, cyanosis, edema, murmurs, elevated JVP, and basal crepitations also can be heard. Investigations, we will do ECG, we will do echo. Echo will assess the chamber size, valve lesions, and ejection fraction. We can do a chest X-ray, shielded X-ray, to check for cardiomegaly or pulmonary congestion. And we can do routine labs like CBC, renal failure, renal function or liver function, and coagulation profile. Now, how will we manage these heart diseases? There has to be preconception counseling. If the patient has to be told about the risk assessment and the condition has to be optimized before pregnancy, preferably, and the patient has to be started on folic acid, and teratogenic drugs like ACE inhibitors, warfarin have to be stopped. About antenatal care, multidisciplinary obs-gynae and cardiologist and anesthetist is required to counsel such a patient. Regular checkups and echo has to be done. Restrict the physical activity. Prevent infections, especially infective endocarditis, because it can worsen the heart conditions. A patient has to be given prophylactic antibiotics for high risk valve lesions during delivery or procedures. Drugs safe are furosemide, digoxin, beta blockers, and heparin, while to be avoided are ACE inhibitors, ARBs, warfarin, especially in first trimester. Next up is the intrapartum care. In hospital, delivery is prescribed to the patient, and vaginal delivery is preferred in most unless obstetric or cardiac indication is there. You have to minimize stress and pain. Early epidural analgesia will help in this. This intrapartum care is assisted second stage, forceps or vacuum to avoid maternal effort. IV fluids are given with caution to avoid overload, and continuous monitoring of BP, oxygen saturation, and pulses there. Lastly, postpartum care. Risk of pulmonary edema is highest in first 48 hours postpartum. There has to be gradual mobilization, continue medications, and family planning advice to the female can also be given in this period. What can be the complications? The maternal complications can be heart failure, arrhythmias, pulmonary edema, thromboembolism, endocarditis, sudden cardiac death. And the fetal complications can be IUGR, prematurity, congenital heart diseases if maternal diseases are there, and perinatal mortality can be there. So what can be the contraceptive advice given to the patient? In low risk patient, OCPs or intrauterine copper are given. In moderate to high risk patients, barrier methods, progestin only pills, permanent methods like tubal ligation is preferred. And in very high risk patient, sterilization is advised and pregnancy is contraindicated. So coming on to the last topic of this video, HIV in pregnancy now. HIV can be transmitted from the mother to the child during pregnancy, during labor and delivery, and during breastfeeding. Without intervention, the vertical transmission rate is 30 to as much as 45%, while with proper care, it can be reduced to less than 2%. There are some national programs in India. So this is managed under NACP, National AIDS Control Program, and the strategy is to eliminate mother to child transmission of the HIV. All pregnant women are screened for HIV under RCH and ICTC Integrated Counseling and Testing Center services. The diagnosis. 3-tier testing strategy is done for confirmation as we see in micro. ELISA rapid test at antenatal clinics is done, and if positive, partner testing and early linkage to ART center is also done hand to hand. If the female is HIV positive, then antiretroviral therapy is started immediately upon diagnosis. Regardless of the CD4 count or the clinical stage, we have to test and follow the test and treat policy. The preferred regimen is tenofovir, lamivudine, dolutegravir, TLD regime, which is to be preferred once daily, and ART is continued lifelong. For prevention of mother-to-child transmission, during pregnancy we start ART as soon as possible. We regularly check this transmission or the infective levels on ANC follow-ups, and we monitor CD4 count, viral load, and adherence. During delivery, the mode of delivery depends on the viral load. Vaginal delivery is preferred if the viral load is less than 1000 copies per ml, and elective C-section is done if at 38 weeks if the viral load is more than 1000 or unknown. What is to be avoided is the artificial rupture of membranes and episiotomy unless necessary, and instrumental delivery should also be avoided in such patients. Postpartum care involves neonatal ART prophylaxis. Neonate has to be given syrup nevirapine for the baby till 6 weeks if the mother is on ART throughout pregnancy, and till 12 weeks defirapine if the mother was diagnosed late or is not on antiretroviral therapy. While breastfeeding is not contraindicated, exclusive breastfeeding for 6 months plus ART for both mother and the baby is done in such cases, and mixed feed has to be avoided. What about the infant? Infant follow-up and testing has to be done. Early infant diagnosis should be done if in case the infant is positive for HIV. HIV DNA PCR at 6 weeks, 6 months and 12 months. Antibody testing at 18 months to confirm the HIV status of the child. What are the special considerations? Co-infections, if are present, then we have to screen for TB, syphilis, hepatitis B and C. Around family planning, we have to counsel for safe contraception. Condoms are always recommended. What can be the maternal and fetal complications? Maternal complications can be opportunistic infections, antiretroviral therapy side effects, and risk for tuberculosis. While fetal complications can be like prematurity, low birth weight, stillbirth, HIV infection if interventions are not followed. So early diagnosis, in this we have to do routine HIV testing for all pregnancies. ART, antiretroviral therapy, we have to follow TLD regime lifelong. In delivery, vaginal delivery is done if viral load is less than 1000, and C-section is done if viral load is greater than equal to 1000. What about the infant? Infant has to be given nevirapine syrup, and HIV PCR testing also has to be done. The syrup has to be given for 6 weeks if the mother was diagnosed early and was on ART, and is given for 12 weeks if the mother was diagnosed late or is not on ART. For follow-up, we have to regularly check the viral load, CD4, and infant testing has to be done as well. Okay, so this completes our part 3 of 5 important topics in obstetrics and gynecology. Next up will be the final and concluding part of obstetrics, in which we will be discussing some more important topics, and after that we will switch on to gynecology. Okay, so like, share, subscribe. Thanks for watching.